The patient in the last case challenge has advanced post-MI cardiogenic shock with persistent hyperperfusion despite Impella support. He also has severe LV failure with elevated filling pressures and pulmonary edema and clinically important RV dysfunction, as we saw with an elevated CVP, PAPI, RV dilatation, as well as echo findings. For the shock classification, the physiology is most consistent with actually biventricular cardiogenic shock. Stage D is probably most appropriate, but he's very slowly progressing towards stage E. One of the findings for stage E is a lactate greater than 5 and a pH less than 7.2 or being peri-arrest. This guy meets that criteria, so I would probably put him on E. This patient has worsening hypoperfusion state as evidenced by an elevated lactate, oliguria, metabolic acidosis, low cardiac index, and low cardiac power. So given these findings, your immediate next step shouldn't just be to jump to VA-ECMO. There are a few important findings here that you need to first fix. First is you need to confirm the device position with echocardiography and check the waveforms. Because of the narrow waveform that I mentioned and that the inlet is only 2.5 centimeters from the aortic valve annulus, this needs to be fixed. It needs to be closer to 3.5 centimeters. Next, assess the RV failure, see how much it's affecting LV filling. If the LV preload is really low due to severe RV failure, maybe an Impella RP may be indicated to help support the RV function. Further evidence that the Impella needs to be adequately positioned is the significant hemolysis with the high LDH and low haptoglobin, as well as the plasma-free hemoglobin that you're seeing, along with increasing suction alarms. So this tells you that, okay, the Impella is not in the right place. And despite you getting 3.2 liters of flow there, that just because you have that flow on the Impella does not mean you're getting adequate perfusion and forward flow. So first priority is that to actually fix the positioning. That's the overall lesson, that just because you have good Impella flows does not guarantee adequate systemic perfusion, and your management should be tailored to your patient's individual hemodynamics and end organ perfusion. In this patient, the next likely step I would do is reposition the Impella, closely monitor the perfusion markers and see how his hemodynamics are changing. If his filling pressures are not improving, I'd probably put in a right-sided Impella, an Impella RP, and see if that can help improve LV filling and forward flow. If perfusion is still not improving, you may need to upgrade to a 5.5 to get better flows, to get 5.5 liters of flow through the Impella. If after all those steps you are still not meeting adequate markers of perfusion, then VA-ECMO would be considered in a patient like this.